and Charlotte Kohler from Kohler Healthcare to do a presentation for us on the 2023 CPT Annual update. Really quickly before we get kicked off, I'm going to do just a couple quick housekeeping items. First, we're going to have 3 polling questions throughout the course of the presentation. Just keep in mind, if you, in order to get credit for the CPE credits, you will need to answer all 3 of those polling questions. And then secondly, we're going to have a Q&A session at the end of the webinar. If you have questions that come up throughout the course of the presentation, please just enter them into the quick Q&A module. And again, we'll get to them after the presentation. With that being said, and without further ado, I'll go ahead and pass it off to Lauren and Charlotte.
Thanks so much, Lucas, and good morning, everyone. Charlotte and I are, we're delighted to be with you on this Tuesday before Thanksgiving. We are also excited that attendance has grown so much from last year, and last year's attendees voted and said today would work well to talk about the January 2023 updates. So that's how we are ringing in the holidays. Please note that the annual American Medical Association AMA Symposium just ended Friday afternoon, and it's only Tuesday morning. So KHC has been working around the clock to be ready for today. To that point, if there are any accidental typographical or formatting errors that we notice or any of you notice, we will work to correct those after today's event, and Lucas can send out a clean document once it's ready. Please do not panic that this presentation, I'm going to move to that slide actually, is, let's see, is 127 pages. Please do not panic when you see that. We do have a table of contents, so you can refer to this document after today's presentation. And we are not going to read to you, I promise you, 127 pages in under 90 minutes at this point. We will purposefully be skipping over many of the slides because we know that for those of you that need detailed information on these updates, you either already have your own resources, or you can again read this document in its entirety after the presentation. Charlotte and I have done many speaking engagements over the years, and we both have the same philosophy. Our goal is to educate, not intimidate or overwhelm participants. So whether this year is your first year learning about annual CPT updates and you're still trying to remember that CPT stands for current procedural terminology, or your 26th year like myself, we hope you bring some knowledge back to your day jobs. To that point, we're hoping that each of you can take a step back from the stress of your jobs in healthcare and use these 90 minutes to maybe remember one of the many reasons you probably entered the field of healthcare to begin with. Most of us on today's webinar are financially educated and trained. And if you are like me, you are amazed by what doctors, nurses, Charlotte, who is on one of our educators today, is a nurse, technicians, and so many other types of clinicians. Everything that they do each day. You're probably also amazed by the work of scientists. Because of this, we're excited to hopefully be able to share several of the newest innovation and technology related codes today. We're going to purposely try to share information in layman's terms so that it makes sense to everyone. We, all of us, we don't just work in healthcare. We also, we're patients, we're care providers to our families and friends. So some of the technologies we'll bring up, hopefully you can relate to. Hopefully you're excited about some of the advancements. We have a slide in our presentation that the disclaimer slide. And just to remind everyone, this 90-minute webinar is not a substitute for obtaining and reviewing the latest CPT manual and the Level 2 Healthcare Common Procedure Coding System Manual, HCPCS, to better understand all of the code updates that are going to be needed for coding and billing purposes. But we think it's a great way to dive in to this new year, not being fearful, of these updates and all the work that needs to happen to get ready for them, but rather be expectant of better health of our country, both mentally and physically, when you see some of these advancements. As you think of questions or you have thoughts or ideas that you want to share, the Q&A box is available, so we would encourage you to use that. We will be getting a copy of anything that is input in the Q&A box, and if we don't have an opportunity to answer a particular question live, we will send a written response, and Lucas will make sure that that is distributed to all of you. All right, as I wrap up with these opening remarks, and I'm about to turn things over to Charlotte for our first section of the presentation, just want to let you know, we're right there with you. We're learning, all of this is new. As you're moving towards January 1st and the go live of system updates and educating staff, try to remember that everyone in the country is right there with you. Do your best. It's going to be fine. And last but not least, if you are in need of a CEU, if you have an AAPC coding certification or another coding certification that accepts AAPC CEUs, Kohler was happy to sponsor that for you today. So there's some information at the end of the presentation on how to get that certificate. And Lucas will send you your CPE information after today's event as well. So Charlotte, I'm going to turn it over to you to dive into one of the largest area of updates this year, and that's evaluation and management.
Okay, Lauren, let's go through the next couple of slides just so that we can see them. You've got the total number of changes. That was just for informational purposes, so people can see that, yes, there are areas that have a lot of changes and some that just have a few. And some of them, not to be, as you say, frightened by them, are minor changes in wording, but major changes in the approach we're taking. So as Lauren said, we spent our time at the AMA conference, which is basically over 3 days, about 2 days worth of education. But as we get into E&M management and we go to the next page, the summary. So we've got some incredible changes, although they really do impact the professional fee providers. Some of those issues will spill over to the hospital side. And many of you are also responsible for the pro fee side within your organization, or you are working in a medical practice. These changes that I'm going to talk about actually started in 2021, and they hit the office codes that moved from, and I'm going to use some lingo here, what we call the 95-97 guidelines, in which history examination and medical decision-making were the factors that you had to meet to be able to select a code. We moved from that to go to medical decision-making and time. We skipped 2022, but in 2023, as we're going to see today, we made the rest of the transition. The goal was to streamline the documentation, the selection of code, to actually come to an agreement between the AMA and CMS. Prior to this complete change, as I talked about the 95-97 guidelines, you couldn't go to the CPT book and find those guidelines. That was outside of the AMA. Now, as I talk about medical decision-making and time, those are all now embodied in the CPT book. Go to the next slide. So the changes occurred because there were what they considered to be sort of like-kind services, and yet we had all these different code sets. I'll tell you right up front, I'm not sure I necessarily agree with all of them, because there are the repercussions from that. And one of those are going to be, as I talk about inpatient and observation. When we had similarities, they wanted to bring them together. Where they had codes that had sort of disparate components to them, they broke them apart. So they wanted to say, basically, we moved from a service to a day of care. The E&M now covers a day of care. So if a doctor or a provider looks at the medical records prior to seeing the patient, pulls up any kind of diagnostics, that now goes into the determination of the E&M service. They got away from forcing a history and forcing an exam and saying only when they're pertinent. Give us the pertinent information instead of requiring all these bullet points that had to be completed. The medical decision-making guidelines, as I said, they are actually now in the CPT book. That makes it a lot easier than saying, okay, I've got a CPT code, but I don't have the rest of how do I do it? Now we have it. They made some changes. Before we had the 99211 code that we often use when there was no physician presence requirement. They aligned that now with the emergency code 99281. They also removed all of the examples that used to exist in the back of the CPT book. There is now a separate book for that, and they've been moving away from providing examples in the back of the CPT book over time. As one can guess, time is not an element that will be used in the emergency department. But again, the goal here is to lessen the amount of administrative work. Next slide. Here's a summary. We're not going to go through every one of these, and you're saying thank you, I'm sure, but especially those that are in sort of the middle there that have to do with nursing home and residential care. Time and efforts there, they're in the book, and you can review those. Next slide. To really show you, because I think seeing things is a lot easier than just talking about. I talked about when we go back to 2022 and we look at 99221, which is your lowest level of admission, initial care, you see that we've got in bold history, examination, and medical decision making. If you take a comparison to 2023, you'll notice that all those bullet points are gone. And we see that it is, as we read through it, very important pieces. They changed it from inpatient or observation. They also made it per day for the evaluation of a patient, which requires a medically appropriate history and or examination and a straightforward or low-level medical decision-making. So again, medical decision-making, there wasn't a chart prior to this, but the new chart in the CPT book is the one we're going to be using. And then we have the total time. So unlike what it was in prior years where it said, at the bottom paragraph, it said usually the problems require admission are of a low severity, typically 30 minutes are spent. We went from a typically so many minutes spent to actually saying the time needs to be 40 minutes and it has to be met. Next slide. So just as a summary of all the ones that have now been collapsed into inpatient codes, there's our list. Next slide. All right, so as I indicated, this section is now called inpatient and observation care. We don't have two different sections anymore. So it seems a little crazy how they can say observation should be part of inpatient. I think it's going to exacerbate the problems that patients already have with, okay, am I inpatient or am I observation? Because that's outpatient. But keep in mind that we're going to need to use the right place of service. And Medicare is keeping their requirement for the time element. Next slide. So as a summary, again, you can see we've got 3 codes. You can see we've got medical decision-making and time. There is a separation between initial and subsequent. There is the possibility that more than one physician needs to see a patient even during an initial or subsequent day. And they will report those services, and we will look at using modifier 25 for a subsequent code when it's the same doctor. Next slide. This one is one of those situations where there is both the admission and discharge on the same day. So you can imagine there has to be at least 2 visits. There has to be the admission, there has to be the discharge. And again, we have our MDM and also our time. Next slide. Outpatient consultation revisions to incorporate observation and the leveling update. So what they've done here again is they're trying to align each of the different code sets so they have the same criteria. They're also looking at some minor changes. The concepts haven't changed. They've added the qualified healthcare professional, whereas before it said physician. And they deleted, there's deletions in the concurrent care and the transfer care. Next slide. So again, it's called inpatient observation consultation. So it's all together. And we can see that we've got our 4 levels and we've got both the MDM and also the time. They deleted the 99251, just as last year, they eliminated the 99201, which was a new patient lowest level. It's really used so seldom and that it wasn't worth having a code for it. There is a limitation actually in the CPT of having 1 consultation per admission by the same doctor. Next slide. So then we get to the discharge, and we can, again, here's a code. It was before just hospital discharge, and they said, well, wait a minute, it's so similar. We can add observation to that and have either one of those meet the requirements of these codes. So they put the codes in, both sections of inpatient and observation. And then, of course, the place of service will be the distinguisher on where it's actually taking place. Next slide. ED is interesting. They did not change the codes. They changed the level of medical decision-making, which are listed here, and 99281, because there's no physician involvement in that or qualified healthcare professional, there is no medical decision-making. There is no time element. And I think that it's going to be interesting to see how that actually interplays with our requirements under EMTALA, the 99281, how payers are going to look at that. Next slide. There's some changes in the care plan oversight, and they collapse those into management or principal care management. Next slide. So here's a change. We have a new code that talked about prolonged, and prolonged services is one of the areas where they actually separated prolonged care out into components that made sense as it related to the code set that it went with. And keep in mind that CMS still has their own G codes for this, but you can see the changes that occurred in both 99.417 and 99.418. This is an interesting, I want to bring up one more thing in this slide. We have to keep in mind that when we have the plus sign, which is an add-on code, there is a tendency, I think, for non-coders to believe that if you have a code that has a plus sign, that it has to go to the code above. And you can see in this case, each of these prolonged services with the plus code is actually an add-on code to the other E&M codes. Next slide. Prolonged care, again, collapsed into other codes. We can see that we're using now, we got rid of the ones that were for home and residence. We got rid of the ones that were for inpatient and observation, and we deleted those code sets and pulled them into 99217 and 417 and 99418. Next slide. So when we take a look at this idea of prolonged care, we're talking about that there can be prolonged care other than the date upon which there was a face-to-face encounter. Go through these prolonged care areas to the extent that you will use them. They're not used on hospital side, but they're used on the physician and provider side, and see that what counts and what doesn't count. Note also that there are some payers, Medicare in particular, as you look down to the last bullet here, that Medicare has deemed this to be an invalid code. They want to use a G code. So you'll have to take a look at whether we're talking about prolonged on the date other than the face-to-face. And as we go to the next slide, more definition on that, and you can see how we add that. Go to the next slide. And so here we have, again, a different kind of prolonged. But this, again, the words are very important here. The key word here is supervision. So this service is actually performed by other clinical staff. So it says prolonged service with physician or other qualified requiring the professional supervision. So this didn't really change in 2023, but in fact, we're having the clarity to make sure that we are using the right kind of prolonged code with the circumstance, the place where the patient is, and the codes it would attach to. Next slide. Again, really quite different here. Keep in mind that, for years, nothing was ever paid for non-face-to-face, but we're actually seeing that there is an understanding of the need to have other qualified professionals involved, other staff involved, and it includes now, as we say, the phone service, which is not face-to-face, but has been really critical during COVID. Next slide. All right, this one, the code itself didn't change, but keep in mind, this is all on the same date of service. It doesn't say that on our slide, but note that, please. So all these things still are the same as they were. Note that we went from 50 to 60 minutes and that the face-to-face piece has been eliminated. So it's with the patient and or family or caregiver. Next slide. Transactional care cleanup. Again, part of what they wanted to do here was to match it all up. And since we got rid of the elements of history and exam, they also wanted to make sure that they had the clarity with regard to medical decision making. So they just cleaned up the wording on this. So we have a moderate level of medical decision making during a service period, and this is a face-to-face, and it's within the 14 days of discharge. I think that we all saw these several years ago when it came into place, where both Medicare and CMS were looking at making sure that there was a follow-up after a patient was discharged. Next slide. Yes, it's still part of E&M. It has to do with the delivery room attendance and the delivery room resuscitation. The key point here is that it can be used in addition to your inpatient codes as well as critical care. It is not an add-on code, so it doesn't have to have an E&M, the 99221 to 223, but it could. Next slide. So to recap, before I turn it over to Lauren, inpatient E&M codes now are, those the inpatient and outpatient are aligned. They collapsed the codes for observation into inpatient. They deleted and collapsed codes for the annual nursing facility assessment. They felt that that wasn't needed. Again, I didn't go over it today, but certainly take a look at your residential services, custodial. It's now been renamed and redefined just to make that clear. And again, a lot of deletion of the face-to-face prolonged care and the elimination of the Appendix C. So Lauren, you want to pick it up?
Sure. Thank you. Thank you so much, Charlotte. And that was truly amazing how much material Charlotte just got through in a short amount of time. We did receive some questions, and remember, if we do not have time to answer those live, we will respond to them. And there's going to be a lot of questions with the E&Ms this year with all those changes. Okay, so before we move to our first polling question, just to piggyback on everything that Charlotte just said, lots and lots of changes going on with E&M. So expect to see a lot of updates coming from the AMA, clarifications. The MACs are going to be, providing their clarifications. There's going to be a lot of information. And we would say, ask those questions, whether you're going to reach out to a consultant like us and say, how are you interpreting, or if you're going to go, straight to the AMA or CMS. That's only to be expected with this, especially with this first year with this many changes. Yes, we did have all those years or all those updates with the outpatient, but this is a lot. So there's also a HCPCS that's been out there, I think, for a year or two that relates to intensity, the G2211. And CMS briefly mentioned during the symposium that they were going to provide some clarification, or might have already provided some clarification on that. But we just have a few more notes on this slide. I know as a non-clinician hearing the physicians speak last week, they said multiple times, really avoid always the case type rules. That the medical decision making that Charlotte was talking about, that really should be patient dependent. The same condition could be very high risk for one patient and not as high a risk for another patient. So just try and keep that in mind. And then for any of you that have been working on the split and the shared E&M, there are FAQs that are online, and again, keep submitting questions. Before we move to our polling question, just wanted to mention that there has already been errata released by the AMA, so we have those links here. And that's going to continue to grow. This is a lot of information, and even the AMA can make typos and errors. So we have those websites. That second link is what Charlotte referenced. There's a separate E&M book that goes with the CPT book this year, and those are those updates. Okay, Lucas, would you mind launching our first polling question?
Not at all. Just as a reminder, everyone, we'll leave it up for about 60 seconds. And if you want credit for your CPE, please make sure to answer these questions. All right. First question. Were you expecting the E&M updates and feeling ready for January 1st?
Okay, as we're waiting for those results to pop up, and Lucas will show the results on the screen. Do not feel bad if you're struggling a little bit. This is a lot. So again, do your best, and there'll continue to be information. So we're going to move on to surgery. Lucas, are you pretty close to being able to publish?
Yeah, absolutely. We'll go ahead and end it here in a couple seconds. All right. And we'll share the results quickly. We had 49% say yes, 17% say no, 24% say not sure, and 10% say non-applicable to me and or my organization.
Great. Yep. So kind of what we expected, and time marches on. All right, surgery. We're not going to spend a lot of time in this section. Surgical codes are very, very specific, obviously. They would typically be assigned by a coder that's reviewing documentation versus something that would be maybe in a hospital charge master. So again, we're not going to spend tons of time, but wanted to draw your attention to the major updates that happened this year relating to hernia repairs. So you can see on this chart, that's those were 35 of the 72 updates. So that was a focus area, and you'll see that a lot of times with CPT updates where a particular area will just get completely redone, and that's exactly what happened with hernia repair. So again, we're not going to go through each one of these slides, but just going to mention some highlights that were mentioned in the symposium. The integumentary, so the 15,000 codes, those updates, when you're reviewing those updates, they were related to the fact that there are procedures that no longer have a global period. They are just the subsequent services can be billed separately. So that's why you're seeing some updates for clarity made to these sort of post-surgical services that would happen. The musculoskeletal section, sometimes people refer to it as the orthopedic section. Minor updates made this year to the codes themselves, but very significant updates made in the guidance surrounding coding in this section. So if this is an area that you work in, you're going to want to check on that guidance and make sure you're using the existing codes appropriately. The respiratory section, there was one new code added this year. Cardiovascular, every year there's always several codes added to this section. And keep in mind, when you look at some of these new codes that are out there, and sometimes you'll think, well, wouldn't that already have existed? Should that already be an existing code? These services are happening, but what happens until they get a new code assigned, the coder must use an unlisted code. So every year you always see several new cardiac procedures, and that's what's going on. They're putting codes that really already are needed. A couple codes on this slide, on slide 43, these relate to dialysis patients. So make note of those. And they even at the symposium shared the current vendor that's associated with each of these new codes. Also, and we'll talk about this a little more when we get to the imaging section, notice that these codes bundle in any guidance that's happening during the procedure. They're bundled in with the surgical CPT code. And so it's important to note that and not code separately or charge separately for imaging. Last update for cardiovascular was a pretty minor one. CPT 35883 had a brand name in it, and the CPT the AMA strives to make sure that codes are always with the generic name. So this was just some cleanup that they needed to do. All right, so as was mentioned, the major update in the surgical section this year relates to hernia repair. And what they did, or what they realized, is that the way hernia repair codes were set up historically, where they were kind of based on the approach that the surgeon takes, really was not reflective of the underlying resources. But instead, really it mattered, how large was the hernia, where was it located, and was this the patient's first hernia, or how are they having recurrent issues? You see some terminology on this slide that I know I had to look at to make sure I know, what is the difference between reducible and incarcerated or strangulated? And it actually makes kind of logical sense. A patient with a reducible hernia means that they are able to put the tissue back in, what has protruded and is bulging, they're able to fix a little bit easier than a situation of where the tissue is actually trapped, and it's a much more involved procedure. So, we do not have time to go through all these slides, but that's what's happening. They are adding many new repair codes and then deleting all of the old hernia repair codes. And they even have a chart, and we have this on slide 49. They have a chart so a coder could keep track of now all the different rules and when to apply the CPT codes. So again, that was the major updates in the surgical section. And as you can imagine, when they make significant code updates, they also make guidance updates. So a lot of additional guidance out there too. All right, some minor revisions in urinary. Really, they said they were just trying to bring the terminology up to, up to current, the way that these services are referred to. So we have some like kidney stone related services that have been updated. Let's see, male genital, there is a new code out there. It's for a laparoscopic procedure. Prostatectomy, the removal of the prostate gland, codes for that already exist. But if you look at this new code, there's a lot of different services bundled in with this code. So this code is new and would have been falling under the unlisted code historically. All right, the nervous system, the 60,000s, just like we were talking about a few slides ago, they bundled imaging into some of these injection codes. It's not uncommon. A lot of the codes in this section already had imaging bundled. Some codes still do not have the imaging bundled. So again, it can be a little tricky trying to keep track of when the imaging can be separately coded or charged and when it cannot. And the method to the madness, I know when this first started happening many years ago, working on the hospital side, I was like, this is really getting crazy and it's completely different facility resources. But the method and why the AMA does this is if imaging is almost always used with a particular injection or whatever the surgical procedure is, that's when they choose to bundle it. So there is a reason that they do it. Does make it a little challenging sometimes. Minor updates in the I section. That was really just kind of bringing things up to standard nomenclature. Auditory. Okay, this is sort of a follow-up from last year. So last year there were all these new added codes for what they call BAHAs. And BAHA stands for bone anchored hearing aids. So they added all the codes, and what they found is as these codes were being used and as clinicians were becoming more and more familiar with them and developing, their techniques, that they needed more codes that were a little more specific. And so you can see where they revised the codes that were already out there. And then on the next slide, they actually added new codes. And again, they're doing that because the resources involved when you're removing more, larger amount of bone from the skull, that's obviously more involved than when you're not. So they definitely made some changes in this section as well. Before we move from surgery, I just wanted to mention, again, if some of this was a little bit clinically overwhelming, remember what we're trying to kind of give you a heads up about is, let's say in February, you start noticing that you have claims for outpatient hernia repair that aren't getting paid. Remember that the payer might not be ready. The payer might still have the old hernia repair codes in their system. So that sort of January through March timeframe is where it would be helpful to know, hey, I remember they made major updates to those codes, and that might be what's going on as you're sort of troubleshooting if you're having any issues with denials or kickbacks. So moving on from surgery to radiology. Just a few updates this year in this section of the CPT book. However, when we get to new technology, there are some new imaging services in that section. But as far as imaging, CPT code 76882, which is a limited ultrasound code, they made just a minor tweak to this code. And the reason they did that is because they were adding 76883. And if you look at the description for that ultrasound code, that would be a study where it's the entire course. They stressed that when they were talking about it. So if, if a provider is just looking at a very limited section of a nerve, then they would use 76882. But if they're trying to look at the entire, for example, in the code, they mention an extremity, so they're looking at, the leg and they're going to trace that nerve all the way through, then the new code would come into play. A few nuclear medicine section updates this year too. But what they said about these updates, so these radiopharmaceutical localization of tumor codes, these are diagnostic procedures used to detect cancerous growth in the body. And they can be there. If you notice the codes that are on the screen, they all say single day imaging, and they all are for single day imaging. But there had been a little bit of confusion as to when you would consider it to be a multiple or single area. So they added in some clarifying language there. If anything, it sounded like some providers might have been undercoding. Maybe they were concerned that it didn't meet the criteria to be multiple areas. So they did add in some language to help with that. So that was actually it for the radiology section, again, until we get to new technology. So looking at lab, lab has been fairly predictable the last several years, where you're going to see quite a few proprietary lab analyses codes, and we'll talk about those in just a few slides. And then the next common updates are in molecular pathology. That actually wasn't too bad this year. There were 5 new codes and 3 revised codes. Just so everyone's aware, when this first started, the molecular pathology codes, and there have been years where there are so many new codes added. This is the study and diagnosis of disease through examination of molecules within organs, tissues, or bodily fluids. So I wanted to read that just to make sure everyone is on the same page what these tests are. And they've been around for several years now, and again, can help providers when they're trying to diagnose patients with certain conditions. So again, some updates made, and that is not at all uncommon. So make sure if you are using any of these codes that you do make the updates for the new ones. And then the set on slide 69, these new additions directly relate to the revisions on slide 70. So they did some clarifying between RNA, ribonucleic acid, and DNA, taking you back to your high school biology class, but they did have to make some updates for these series. Okay, chemistry, for being a huge section in CPT, only had 1 new code added, and it relates to a medication that actually is used for the treatment of patients with ALL, acute lymphoblastic leukemia. So there is a new code out there for this particular medication intervention. Microbiology, several updates this year for that. One of them, the first one, CPT 87467, which relates to hepatitis testing. In case you look at that and think, well, I think we already have a code for that. That's because there's a qualitative code, but this year they added a quantitative. A qualitative code is less specific, and then a quantitative is going to give a little more detail. So they did add a code for that. And then there's several infectious agent detection codes that have been added. I know one of the questions I had, well, what are they doing today when they're testing for this particular bacteria or parasite from ticks, because that's what some of these words mean. And they have not otherwise listed. They have some generic codes that are used today. And once they find out that they have a high enough volume or they want to separately track specific bacteria, that's when you'll see codes added. And that's exactly what they did this year. We also included CPT 87913, but that is not a January 1 update, and you may recognize that and already have that in your system because of COVID. All right, so proprietary laboratory analyses, PLAs, these tests are performed by a single lab, in the country. It's only one lab that's doing it, and they are constantly adding new ones quarterly and constantly removing ones that have been added too, because sometimes the lab either stops offering that test, or it's no longer needed, or it might have got promoted and now has its own 80,000 code, because maybe it's moved from being specific to that one lab to being more universal. So we're not going to go through all the details of these PLAs, but because there's sort of a revolving door and so much activity, we did include the website from the AMA, where you can kind of keep up with what's going on, which ones are added, which ones are deleted. And every year we, Lucas, we're almost ready for our next polling question, because every year we like to know how many folks are using these. When they first started, it was nobody, but really growing each year. So Lucas, can you launch the second polling question?
Absolutely. We're going to go ahead and launch it now. Just as a reminder, folks, we'll keep it up for about 60 seconds or so.
All right, and this one again is just trying to see who's using the PLAs, who's getting paid for the PLAs, even more important. Okay, while we're waiting for those results to come in, considering all the material we have, we're gonna keep on rolling. So the medicine section, and Lucas, just interrupt me when you're ready to publish.
Absolutely, yeah, we'll keep it open for another 15 seconds or so.
Okay, great. The medicine section is our hodgepodge section. If the code didn't belong in any of the other sections, it ends up here. And not too bad this year with updates. The highest number, which should come as probably no surprise to most of you, was in the vaccine and the vaccine administration sections.
All right, Lauren, we have the results here. Very quickly, I'll share them. Yes, 9%, no, 13%, not sure, 56%, and not applicable to me and or my organization, 22%.
Thanks for sharing that, Lucas. Yep, see, but again, that first year, it would have been like 0% that said yes. So definitely growing with time. And I think a lot of us noticed some of the PLAs relating to COVID as well. Okay, so the medicine section, these are your 90,000 codes. So you can tell we're getting closer to the end of the CPT book now. Again, lots of updates for vaccines, and they are also a revolving door where there's constantly new variations. And you may be saying, well, wait a minute, I thought I already had a code or a charge for that. Well, it might be the third dose or the booster dose, bivalent now coming out. So again, we included the AMA website, which has the sort of running list of all these codes. So hopefully that can help you as you're trying to keep up and keep your systems updated. I know all eyes are always on COVID and those vaccines, but there were some other updates made relating to vaccines, and wanted to draw your attention to the RSV one, the respiratory syncytial virus. You've probably been seeing in the news, lots of outbreaks of that right now. So there is a vaccine for that. Now, these new vaccines might not, at least as of the time we were putting this together, might not have their FDA approval yet. Hopefully that would be coming soon. And the RSV vaccine would be for adults age 60 and over and pregnant women during their second or third trimester. So again, it's exciting to see, when we have sort of these scary headlines, of RSV outbreaks, but then we see a vaccine that's coming, so there is, a lot happening, but there's also a lot of clinical responses to what's happening. All right, moving into the eye section, orthoptic training, there was, I believe the code 92065 that you see on the slide was actually added last year. And now this year, they're already revising it and they're adding a new code, because what they found out was sometimes this training is performed directly by the doctor or other qualified healthcare professional. And then sometimes it would be under the supervision. So they break codes out that way a lot because remember, they're trying to understand the resources involved, and the resources differ by the care provider. Few other updates to the I section, and we're not going to dig in too deeply to these, but I wanted to mention, you see the word autonomous on slide 79. And this is kind of a critical word that we're going to talk about when we dive into some of the new technologies. But it's a much more advanced ability for, so this is retina imaging, this particular code. Not only can this technology, identify what's going on with the retina, but it actually has the capability to do analyses that can even provide a diagnosis and a treatment plan for the patient. So kind of fascinating how far things have come. And we're going to, again, dive into that a lot when we get to some of our future slides. There is also a new code for quantitative pupillometry. This is the study of where they measure the size and reactivity of our pupils. And apparently by doing that, they can predict and diagnose different conditions and be a little more proactive about it. So now there is a code for that. This service had been happening, but again, was using an unlisted code. Audiology, no updates in this section this year, but they mentioned during the symposium that there is a brand new modifier, the AB modifier, that would be applied if an audiologist is performing a non-acute hearing assessment service without a physician order. So they're going to allow and cover services when they're performed that way, but they do need that modifier. I'm assuming they're going to cover. I'm not sure if they said that specifically, but I think they were still planning on covering, but they wanted to know. Okay, cardiovascular 90,000 section of medicine. So some updates in the cardiac catheterization section where they are adding in some specific codes relating to certain injections that can happen during a cath case. And again, not to sound like a broken record, but these could already be occurring today, but now they have the specific codes to speak to the fact that they are occurring. All right, mental and behavioral health. Want to talk a little bit about the codes that were added. There's actually a new section in medicine for a multifamily group behavior management. So this, they gave the example of perhaps parents are dealing with pediatric obesity in their children. They could be in a group like this that is helping them to know how to best help their children. And at the same time, the children could be in a psychotherapy group or something like that. So it's very interesting when they were sharing about this code. They also mentioned sometimes it can be used for parents of children with ADHD. So this is kind of its own new little section. And what they made sure to note, it has to be more than one family to use this code. And maybe that sounds logical to you, but they did kind of spell that out. And there's a lot of guidelines that must be followed that are in the CPT manual. And before we move from this slide, I just want to mention that, each year we've been having more and more of behavioral mental health codes added. The CPT book does contain guidelines for those. So if it seems a little confusing, a new code, and you're trying to figure out, am I doing this code? Should I report this code? Keep in mind, they have a lot of guidelines to help with these. Charlotte, I don't know if you want to talk a little bit about the cognitive behavioral monitoring. I know that one was kind of fascinating too.
Well, it is. And I think, as you said, they're really looking at and have been taking technology and moving it into how can it assist the provider of care in understanding what's going on better. This was looking along those same kind of approach. The other piece that has been increasing is the idea of remote. So, before, if we think about medicine years ago, you go in, you get hooked up to something, it would test you, and then you'd leave. Now we have, over these last many years, been moving to this remote therapeutic monitoring, so that there's a combination, as we'll go further in technology, there's a combination of recording and transmitting that information back to the ordering provider, but also in some cases, and that's not here, but in some cases, actually, the technology helps to contact the patient, get the patient involved. So here what we have is, you can see that it's a device supplied, and this device is not in lieu of the practitioner's efforts and the codes that they would use for their professional service. This is really, quite frankly, it's sort of a technical code. Again, another change is going on in CPT, but you can see where we've got scheduled recording or programmed alerts and transmission to the monitor, to monitor cognitive behavioral therapy each 30 days. So if it's less than I think it's 16 days, you can't use the code, but it is for each 30 days. And you can see how they have changed it to be much more specific. So originally on the 98975, it included respiratory, musculoskeletal, but what you see now is that they have broken that apart so that they can actually monitor each of those, because they mean different things.
They really made that 98975 more broad.
That's exactly right. Right.
So they kind of opened the door, Charlotte, like, okay, this year they added this type of monitoring, but who knows what's going to come like next year. So.
That's right. Right. So again, keep in mind on this, because the technology, the new technology, is just fascinating.
It is. Which brings us to our next slide, where we want to talk about some of these technologies. Very exciting technologies. Again, I'm thinking you'll be able to relate to many of them, whether it's your own personal health or a friend or family member. Okay, so lots of updates. No, we are not going to go through all 68 new codes. You'll also notice in this section that they have a lot of deleted codes. That happens every year too. So with a category 3 code, if it's not being used, if the usage on it is very low, it can then return to being only reportable by an unlisted code. So when we see deleted codes, and we have a lot of those listed in this presentation, I often wonder, is it because no one was doing the technology, or is it because individuals were not reporting it under the new technology codes? So it's super important that if a provider is performing the service, that they do use these T codes. Now, is that an easy reimbursement? Are all payers reimbursing for T codes? Unfortunately, no. But some are reimbursable, and the way to sort of, almost force the payers to have to really look at these technologies and see if they're going to pay for them is to use them. So again, we're going to highlight some of these codes, and we've carved up the new technology into 2 categories this year. The first one is digital medicine, and then we kind of have a catch-all for all the other new technologies. It really is, yes, Charlotte.
One of the points that we just need to make is sometimes too, the technology changes. So it will be deleted and or put into something else, and not a direct graduation to a level 1 code.
You see that a lot, Charlotte. I'm glad you brought that up, because you'll see where the T code was written maybe very broad, and then they might actually carve that into multiple CPT codes when they move it to a category 1 code, or the opposite. They might take out components. So that whole time it's a T code, they really are kind of studying it. Like, how is this being performed? Like Charlotte said, has it changed from what we originally thought when we set up the code? So definitely a lot of activity in this section. And, Charlotte, I hope we can kind of tag team on this slide a little bit, because it was a lot of information coming at everyone. Technology is not slowing down. Innovation, if anything, is speeding up, which is great for our health. But from a coding perspective, it's important that everyone is trying to stay on the same page. So as these new technologies are developed, trying to determine what level of ability, or I don't even know what word to use, Charlotte, but you can have all the way starting at assistive, which means this technology can detect what's going on with a patient, and we've had that forever.
Like a Holter, right?
Yes, it knows something happened. But then you have augmentative. It knew that something happened, and it's analyzed, or it's quantified what it is that happened. And then now look at artificial intelligence and robots. Autonomous means, and they have different levels now, levels 1 through 3, that it can do even more. I don't want to say that we're completely replacing people, but Charlotte, when they were talking about some of these technologies, I mean, it is amazing.
Well, not only is it amazing, and I have to say, this is the part of was pretty exciting, but I think it removes some barriers that have existed, because when a provider sees a patient, you only see what you see at the time the patient shows up. And so much of this is now allowing for a much broader period of time in which to evaluate what's going on in your body. And so I think it's just utterly amazing.
It is. And so as you're kind of dealing with some of the challenges of coding for these services, try to keep that in mind. I mean, the benefits to patients is huge. But what they've done is, last year they already had the Appendix P, and that's that's where they will identify all codes that could be provided via telemedicine. Well, now they've added new appendices that are trying to kind of keep up with, they call it taxonomy, but again, trying to figure out what these technologies, what buckets they fit into, so that we can hopefully keep everyone on the same page. Not going to be easy. But they also added an Appendix T for audio only. So you'll probably see some psychiatry type services and other services in that appendix. And how they did this, if you're questioning that, essentially, if a payer out there is allowing payment for a certain service to be either audio only or real-time audio visual, they put it on their list. So unfortunately, when you see that whole list, that does not mean that all payers are allowing that particular service to be provided that way. But that's what they're using to try and update the CPT book. I did a quick skim of the errata that was just released, and it looks like they're already making updates to these appendices, because things are changing by the minute. So a lot of good information in the CPT book that definitely did not used to be there. And it's going to be interesting how we keep up with it. Because, all these updates don't just wait for the next January 1, they keep evolving. A few modifiers just to make sure everyone's aware of. I know there's been a lot of communication about them, but 93 is the real-time audio only modifier. And then I think everyone's very familiar with 95, the real-time audio visual. But during the conference, they stressed to definitely use those modifiers. There's a symbol in the CPT book. If you see it and you're wondering what it is, that star indicates that that particular code is identified as being a telemedicine code. And why we wanted to take a few minutes just to talk about all this is, as challenging as it can be sometimes to report telemedicine appropriately, especially when you have payers issuing different kinds of guidance, CMS is using telemedicine data to see what they're going to do when, the public health emergency does come to an end, when they phase out, certain types of coverage. This data is what helps them. So as challenging as it can be, by using the coding appropriately and modifiers appropriately, you are helping them with these decisions. Charlotte, did you want to say anything else, just kind of in general, on the innovation piece before we start looking at some of the technologies?
Well, I think that not necessarily about digital, but you brought up a couple of really good points that I want to talk about for just a second. And that is that you talked here about some different appendices. And quite frankly, most people don't go back to the appendices enough to see the help that they can get from it. There is, in fact, Appendix B that will give you every change that occurred. There are Appendix N that gives you the resequenced. And anybody who goes into a CPT book and you're looking for a code and it isn't where you expect it to be, because they're just picking codes. Do I have a code available? So do take a time, as Lauren was talking about, and look at the appendices. It will be extremely helpful to you as you're dealing with all these changes.
And time consuming, I'm sure, to put them together. So yes, use them.
Yes. Mm-hmm.
Okay. All right, everyone. We have a little more than 20 minutes left, and we're going to use that time to talk about a few of the technologies. Charlotte, I'm thinking maybe we'll look at some of the questions that we've received too, and I know there's some on E&M.
Right.
All right, let's keep going. So technologies, again, I wish we could go through every single one of these slides, but just not enough time. Let's see.
Oh, let's talk about the one you just passed for just a second.
Sure.
Okay, so this is just phenomenal. So they're looking at your face, and they're figuring out through those facial expressions what kind of disease or problem you have. Just amazing. I mean, it's beam me up, Scotty. I mean, we've got amazing stuff going on. So keep going. This
one's good too, Charlotte.
Oh, yes.
Do you want to talk a little bit about it?
Yeah, this is just amazing too. So now, a patient has a stroke, for example, and so they have to learn how to use their limbs. They got to learn how to stand. And what this does is it actually is a monitor that helps the patient and their providers figure out how they're doing with that motion, where they need to work on the different kinds of involvement, including sort of that social interaction. How are they doing? It can seem maybe intimidating to the stroke patient that now we're going to monitor everything you do. But this is, to me, again, how do you see how you're doing and how you're progressing? Amazing. Diabetes, just another one. Not only does it, and you've seen ads for people that, for different things that will monitor your glucose, but this is, in addition to that, this is the software that goes with it, the unit and the software. You have your physician working on the criteria in which they will then give you a dose of insulin. And this is for your type 2 diabetes. So again, amazing.
How about all the changes? So this year with Lab, they have the digitization of slides, and we have a bunch of slides in here with all the different codes that they've added. So the speaker on lab said, this technology has been out there. We're just finally using it. So literally a specimen can be under a microscope and a pathologist can be remotely reviewing it because of the digitization. So everything's going remote, Charlotte. See, so yeah, a lot of slides on that. I think we touched on, this virtual reality. You're reading that correctly. We have CPTs for virtual reality. Charlotte, if you would talk about this slide and the next one, that would be great.
Okay, so this is for the cost of obtaining the technology. This is used during a session with the patient, and it helps with communication, especially what we find interesting because we work on work with autistic providers, is that these autistic children often relate better to technology than they do to people. And so this is that interface that takes that kind of help and provides this assistance then to the therapist who's working with the patient. So go to the next slide here. So this is interesting. We talk about pain management and the things that are going on there to try to reduce the amount of drugs in our system. Here is another use of virtual reality. We may have seen this many years ago, like when you go into the dentist and they put the headphones on you and you're listening to music. This goes on for the sight as well. And so you have a trained observer. There's a virtual reality. We're not using either any or a lot less of sedation or anesthesia. It is, again, a fairly amazing process. They don't want to do it. It's limited to 5 or older. It is the choice of a length of time. And if I recall, if it's less than 10 minutes, I think you can't use it, but everybody's.
I think that they said that too. It must be 10 of the 15 minutes to be even able to charge.
That's right. Okay. So actually it's right on the slide. Thank you.
Yes. So very fascinating. Let's see, we have some other new technology slides. I want to get to some questions before, and we have, some updates and all. So I'm going to go pretty quickly through this section. But this is, again, T codes that are hopefully making improvements. This first one would relate to patients with chronic obstructive pulmonary disease, COPD. So, again, a lot of these new technologies tackling huge issues that are going on. And let's go to, let's see. Oh, the neurosurgery. Wanted to share this because this is fascinating. Again, I am not clinical, so I don't know all the ins and outs. But if you look at 735T, and you think about patients that have brain tumors and they're trying to, reduce or remove the brain tumor. This is interesting. This is a radiation therapy applicator that is a thin, they described it as like a wafer that can go in, that can be inserted. And not that it's the same, but if you think about brachytherapy and what that did for, prostate cancer, because you could put that in and it could continue to work. They described this as being very similar, but with brain tumors. So, just fascinating. Charlotte, I don't know if you had caught the discussion on this one or not, but I thought that was just amazing. Okay, we're gonna keep going so we can talk about a few other updates that relate to, let's stop really quick on slide 116. Remember, we said there weren't a lot of imaging updates in the actual 70,000 series in that section, but they did have several updates relating to imaging. And these are just more situations of where they can take either an image that is from history or now, and they can do a lot more with it, and they can come up with, have more information for the provider.
Right,
So
because before the provider would have to do that imaging themselves. And so
Right.
this does it electronically and just improves the process overall.
Yep. Okay, that's going to bring us to a few updates we wanted to make everyone aware of. Then again, I think, Charlotte, we are going to have time to do some questions. So just a few more slides and then we'll dive into questions. One of the topics that has been brought to our attention, and you will find in the outpatient prospective payment system final rule, is some updates relating to waste modifiers for pharmacy. Now, we're not going to dig in too deep into this today. We do have a part 2 that's coming up on December 2nd, where we will probably be having some more discussions on this particular situation. But just to kind of put that on your radar screen, and again, all the details are actually in the final rule if you want to start looking at that, and we hope to kind of discuss it a little more too as a group. Lucas, we have another polling question, and we just wanted to kind of gauge where everyone is on this whole pharmacy modifier situation.
Yep, and we'll go ahead and launch it right now. All right, folks, we'll keep it up for about 60 seconds.
Yeah, just let us know. Are you concerned about it, or it's not going to be a big deal for your organization? And if you really haven't dug into it yet, we have some options there too. Okay, well, Lucas, we're probably getting close to publishing that. I'm going to go ahead and just talk a little bit about the fact that 2023, yes, we have all these new codes, and we've tried to highlight a lot of them. Lots of things going on this January. Before I dive in, Lucas, are you pretty close to being able to publish the pharmacy modifier?
Absolutely. Yep, we'll go ahead and share it right now. All right, so we had 32% say yes, 22% say no, 25% say not sure, and 21% say non-applicable to me and or my organization.
All right, kind of even, almost even in all the different categories. For the folks that are concerned, again, we have a slide in here. We would love for you to join us. We have a hybrid event on Friday, December 2nd, and that is one of the topics that we have slated for that event. Okay, so again, a lot coming up for January 1st. We talked about that there are also the HCPCS level 2 codes. We did not go into depth about them today, but you're going to want to look at those. Charlotte did highlight, for example, that CMS has G codes that are used for prolonged services. They don't recognize the CPTs, and they use their own G codes. You'll see that here and there where there are codes, even new codes that are developed, that CMS will say right off the bat, no, we're not gonna accept that code. We're not gonna cover that code, but we will cover this. So just important to keep an eye on those. Very interesting where there are dental G codes. So those of you familiar with HCPCS level 2, you're used to thinking of dental and D codes. But this integration between dental and medical care, I mean, that's always existed, but now CMS does have some codes to use for certain patients where they would cover the dental. The No Surprises Act, good faith estimates, that is another topic that we're going to dig in deeper to at the December 2nd event. So we don't have a lot of time to talk about that today, but just remember that co-providers must be included in the good faith estimates. And that's been the rule, but January 1 is where the enforcement is going to hit for that unless anything changes. Let's see, the final rule, just like everyone else, we're still kind of combing through that rule, but you've probably seen a lot of the headlines. There was an outpatient update, but then at the same time, the 340B drug situation happened too. So dollars kind of shifting all over the place. And we have a few other items listed from the final rule, a lot in the rule about rural providers. So want to keep your eye on that. And then 2023, after January 1, watch for some more prior authorization requirements for Medicare. And they also said during this symposium that one of the topics they hope to dig into a little bit deeper are wound care skin substitutes. Not sure if they're going to change the coverage, but just maybe something to keep an eye on. And I'm not sure if we'll see like some significant coding updates next year for that or not. But it was just something that they mentioned. Little plug for our book. We do have like a desk reference guide that has a lot of topics in it. And my contact information is on slide 126 because that is how you get your certificate. So 126 slide, you could find that. And this is the December 2nd event that we've been mentioning, a little more information on that. So Charlotte, if you are ready, we have some Q&A.
I am ready.
All
right. So the first question had to do with, would you please review the 25 modifier for subsequent initial care codes for different specialists on the same day? All right. So the 25 would only be used if it's the same doctor doing another unrelated service other than the admission. So it does not relate to the other specialists, but the same doctor.
Charlotte, why were they using, when I heard that, any idea why it was 25 and not like 27 or something like that? Because I thought 25 always was a separate procedure on the same day.
Separate service. 25 is a separate service of an E&M nature. And what they're trying to do here is they're saying that everything, remember we went from encounter to day in E&M. All the services provided in the day. And so if you've got the same provider and or group of providers in the same entity, the same UPIN numbers, then what happens is, let's say, for example, the doctor does the admission and then 12 hours later, the patient has an episode that doesn't really, or some problem that doesn't really relate to the admission, but it's something else. It's separate and identifiable. So the doctor would use the subsequent code, even though it's the same day as the initial hospital care, but put the 25 on it. Other specialists seeing the patient on that day would code their own services. Let's see, another one similar to it. Can the initial hospital care codes be used once per day or once per admission? And I think I need, based on, we're talking about the hospitalist on the day of the admission, could the specialist use it the following day? I am going to get back on that, but I do recall it had to do with the initial service, had to do with whether it was the initial service for that doctor and not necessarily the initial service for the patient. But I will clarify that and get that back in writing. Let's see. Any change? Go ahead. I'm sorry.
Yeah, I was going to say there's a question about critical care, and I'm glad that was asked, because the way I understood it, there are changes for critical care because a provider can bill for both an ED visit and a critical care.
That's true. But what is interesting, what I liked about this question is that for those of us who use the professional edition of CPT, you can always open it up, and if you don't see any green, you know that it or the code that says the the little symbol that says it's been changed,
Mhm.
that you can see that there really hasn't been a change. That, what you're talking about, Lauren, is really not the code itself, but the use of it.
The guidelines, I think, have changed for that. Yep.
So there is actually no green changes in the guidelines even. So
Even though they were discussing that last week?
yeah, if you look at the CPT book, there's no green.
Interesting.
It's the use of the code, not necessarily the guidelines for the code itself, if that makes sense.
Got it. Okay.
Okay, so we have some prolonged care question here. It can be used on the hospital outpatient side and funneled 99417.
I typically don't recommend that prolonged codes be used
Right.
on the hospital side. I'm curious if anyone on the webinar today has successfully been using them. We get that question sometimes.
We do, but I think what I was trying to say is that in the hospital setting on the UB billing, you wouldn't be using a prolonged service. And what you're asking, Lauren, is anybody doing that and are they getting paid? What I was trying to say is that prolonged service is for the professional fee side and not for the hospital to use on the hospital services billing. But I'd be delighted to hear if anybody's actually getting paid for that.
And I want to double check the status indicator too for
Right.
for those codes too. But yeah, we typically don't see that. But I say typically because this is healthcare and everything changes.
So the next question, and thank you everybody for their nice comments too. How do E&M codes affect how we bill for specialist visits for Medicare and for all commercial carriers that do not accept consultations while the patient is in observation? Currently, we use observation codes for the admitting physician and the office outpatient codes for specialists when patient is in observation. We are a multi-specialty group. We often have physicians with different specialties and other healthcare providers, PAs, nurse practitioners, seeing the same patient for different reasons during the day. So we have a couple of things here that need to be talked about. One is, you're right, we have a problem with the consultation code. A lot of payers, including Medicare, don't like the consultation code and won't pay for it. And so we have reverted back to the services, the inpatient services or the outpatient services, E&M codes. We would still do that and use those codes. Our place of service, again, would indicate whether it was in observation, and the various individual members of the same medical organization, we're ending up, unless you can see that you've got a service that is separately and identifiable, you're going to add those all together. And I think that is a difficult thing to do, because you're going to have to look at the indications of having multiple members of your organization provide the service and whether you can actually build those separately using a 25. The clarity on that is very, very difficult.
So Charlotte,
yes.
I want to respect everyone's time. Is there anything else you want to add on that one before we kind of wrap up and let everyone go back to their regular programming?
No, go ahead, and we will take each of these questions and answer them in writing.
Perfect. All right, well, we just want to thank everyone. We hope this information was helpful. We apologize that we could not go through every code, but as was pointed out to me yesterday as I was preparing, it took the AMA 3 days, so 90 minutes would have been a bit of a stretch. But we do hope this was a lot of helpful information. We hope that those that are interested can join us on December 2nd. And Lucas, is there anything else you want to remind the participants before we wrap up?
Just that we'll go ahead and send the slides out to all those that did not receive them right after this presentation. And then for CPE, for those folks who need CPE credits, we'll go ahead and get those sent out to everyone in the next couple of weeks.
Great. Thank you all so much.
Thank you.
Thank you, Lauren. Thank you, Charlotte.